Our next speaker is Dr. John Tapp, MD. He's a highly accomplished medical practitioner in Bowling Green, Kentucky. And in a discussion that I had with Dr. Tapp last evening, I discovered that he used to, one of the modalities at his clinic there in Kentucky, he used to do chelation therapy until Kentucky said it's illegal to do chelation therapy in our state. He is also a Renaissance man with interests and accomplishments ranging from his primary care practice to his black belt in the martial arts. He sits on several advisory boards and keeps a busy schedule of speaking engagements. In his private practice, Dr. Tapp's objective is to help patients live to an advanced age filled with good health, mental awareness, and vigor. In the area of heart disease management, Dr. Tapp achieves lower risk for his patients by managing risk factors through lifestyle counseling and precise treatment. To determine the appropriate treatment, Dr. Tapp uses analysis and measurement tools that are available to medical practitioners that more precisely test the efficacy of treatment. He's here to speak to us about those tools and his strategy for achieving lower risk for heart disease. We are proud to welcome Dr. John Tapp.
Thank you, Collie, and thank you, Immunolaboratories, and a special thanks to Bruce Collette of IMD, who allowed me to be here with you. And most certainly, thank you for allowing me the time to share these experiences with you. If you'll notice the slide, it says 60, 60, 60. Now, I know it's Halloween, but that's not the mark of the beast. For after each 6 is a 0. That's a cancellation. It stands for 60 LDL. It stands for 60 HDL. It stands for 60 triglycerides. And with this is the introduction to targeted adequate precision therapy as opposed to monotherapy or combination therapy. How many of you would accept 20 extra years of life if it were offered to you? I don't see 100% of the hands. How many would accept living to be 140 and feeling like you were 40 when you got there? Now, I am not going to promise this to you, but what I'm about to show you will give you a sense of possibility. And the concept is engineering negligible vascular senescence from a particle gradient-driven perspective. Now you have to see the sweetie pie. This is after I was single for 22 years. This is how I go into each room looking for each patient and what package of excitement and flexibility and variety they're going to deliver. Do you think I'm going to let her go before me? And if I'm going to be around to be 140, there's a reason why I'm here today. This is a paper that I presented at the Lorenzini International Lipid Foundation in Venice, Italy about 3 years ago, and again to New York about 2 years ago. It's engineering negligible vascular senescence from a particle gradient-driven perspective. Notice the center slides, 1, 2, and 3. 1, 2, and 3 all look similarly. This is a comparison of targeted adequate precision therapy with the Ashkenazi with the longevity gene and the Ashkenazi children with the longevity gene, as opposed to the Ashkenazis who don't have the gene and to the Framingham cohorts. You can see the similarities. That gene confers 50% reduction in hypertension, 50% reduction in metabolic syndrome, 50% reduction in hypertension, diabetes, metabolic syndrome, and confers 20 extra years of lifespan. One of the issues is, what does it do? It enlarges the LDL particle and it enlarges the HDL particle. So can I teach the genes to produce large LDL particles and large HDL particles? The answer is yes, and the answer is right there. Now, I cannot tell you that I can reproduce what the gene does, but this is what we can do with the particles. Don't feel badly like I used to feel before I read this. 6 million medical articles printed each year. It would take me reading constantly 82 centuries to get caught up for this year. This is a Chinese textbook of medicine. Notice the date, almost 5,000 years ago. Inferior doctors treat the full-blown disease. Mediocre doctors treat the disease before it's evident. Superior doctors treat or prevent the disease. But we've advanced from there. This is a typical Framingham assessment for 10-year risk using age, cholesterol, smoking, HDL, and blood pressure. This is America's greatest Zen guru. What you see is what you get. If you only look one place, you'll never see the next place. Think and get out of the box. This is Halloween. If you are here thinking only lipids, you can have two people meeting national guidelines for lipids, no attention to lipoproteins. If you look at the lipoproteins, one will have normal risk, another will have 6 times the risk. So it's no wonder that Tim Russert had a difficulty even having normal lipids and normal treadmill. Maybe as I go further here, you'll be able to see more about that. Did you ever wonder when the hearse went by that you might be the very next to die? One of the first signs of coronary artery disease is sudden death. I'm going to say it again. One of the first signs of coronary artery disease is sudden death. The other one is erectile dysfunction. This is the way I was taught in medical school to look at lipids. Notice all of these studies range from 19 to 35% protection. Patient comes to the physician says, we need to do something with your diet, your exercise, but we can't do anything about your parents or your genes. To that I say that's nonsense. You can't go down, if I went down to the dog pound, brought a puppy home, put him on the kitchen floor, looked at him and said, I'm sorry, puppy, I can't potty train you because I don't know who your parents are. No, we teach the genes what particles we want them to make to enhance our capabilities of stopping the progression of vascular disease and reverse the vascular disease. So we have a better enhancement or a better chance of doing this. Notice this is about 80 to 95%. And most physicians will treat with one drug, monotherapy, or a simple combination therapy for every person that walks through the office, and they get 30%. What would you think if your kid came home from school and had a 30% report card? What would you think of the teacher? Then what would you think of the school? But if you can get 93% reduction in death rate, wouldn't it be interesting to have that? 72% reduction in cardiovascular events. 90% reduction in Hat's trial when you use no antioxidants with the statin. But if you added antioxidants, you'll decrease the benefit by 30%. Now, that doesn't mean antioxidants don't work. It means when you're using them with the statin, you don't get the same effect. How many physicians look at HDL as if they could do something with it? Women always have to have a score of 10 more than the male has to get the same protection. But notice when you're at 25, your events markedly increase. Something happens at 40. That is, once we transition above 40, all the particles begin to get larger in the HDL format. Many people have had coronary angiography. Age 15, you don't see an occlusion of the lumen. Age 40, the lumen is still the same. And this lumen will continue to stay the same until the plaquing is so severe the blood vessel can't extend further outward, and then you get to see the cardiologist. The idea is large particles, larger particles, lower risk. Smaller particles, larger risk. How many physicians do you know that are even looking at particles, sizes, or numbers? This is atherogenicity, small, dense LDL here versus large. These particles will penetrate the endothelium, into the system, into the blood vessel, binds to the proteoglycans, accelerated oxidation occurs, macrophage uptakes begin, meaning white cells coming in, meaning inflammation increasing, foam cells develop, and you get a lesion. Is there a way to adjust that and know that you had adjusted it? So part of the topic of today has to do with what are you really trying to do when you're looking at that patient for the next 10 years rather than 3 months. Can you make a difference? And if you made a difference, how would you know it? And if you use gross tools, can't see it. If you use precision tools, you can see it. What you see is what you get. These are the particles. What's really neat is we can identify these particles with nuclear magnetic resonance testing. Sending in a sonar beam, these will say ping, these will say bong. We count the pings and the bongs and we know where they are. Then we know how to adjust each one of them to make those particles the number that we want and the size that we want. So it's like teaching my little puppy. Those are the particles you find in the plaque. Notice here, LP little a. That is called the death gene. The more of this, the more aggressive one has to be in reducing the lipids. This is an example of an NMR, nuclear magnetic resonance testing. Here are the pings, here are the bongs. We count all of those, and then by using targeted, adequate precision therapy, we tell the genes which ones we want and how many. Targeted means for each lipid, therapy directed toward each lipid, each lipoprotein subfraction, and each particle. Adequate means adequate diet, adequate exercise, adequate drug or drugs, inadequate in dosage for an adequate duration to get a precision effect and measured by precision tools. This is a precision tool. The bridge over the River Kwai has to do with this. Age 2, the foam cells start. Age 18 to 22, as we know from the Korean War and the Vietnamese War, our best, most physically fit men dying on the battlefield already have significant atherosclerosis. The plaque continues to increase until it ruptures. Notice that it bends outward before you ever get an occlusion, filling the vessel with the plaque before it ever occludes the flow. Again, pointing to Russert, normal treadmill. So it's not the stenotic vessel that kills, it's the vessel that has the thin candy shell, if you will, that erupts and touches the blood and causes the blood to clot. This is an example of white cells coming in after the LDLs have come in, generating oxidized LDL-free radicals. The macrophage gets activated, monocyte gets activated, starts gobbling up the fat, making foam cells. This has to do with the cells generating high-sensitivity C-reactive protein, IL-6, and tumor necrosis factor alpha to tell you that we have sick vascular tree. This will tell you about cytokines being generated, tissue factor, which generates the thrombogenesis, and decrease in fibrous cap resistance, taking the cap off the plaque, exposing the plaque to the blood, causing the clot. This demonstrates how the macrophage produces these enzymes, collagenase, elastases, matrix metalloproteinases to take the collagen off to cause the cap to come off and rupture and cause the heart attack or the stroke. This is a coherence tomogram showing this fibrous cap. This shows the lipid pool. This is all that's separating us from death, that little cap. It covers 50 to 60,000 of those plaques that we have in our arterial tree. This is a microscopic representation of the same thing, the cap, the plaque, the ninja in the night. Think now of that pool. Think now of that cap over that pool, and look at this. Change the milieu in the plaque, and this cholesterol can triple in volume in 3 minutes. 3 minutes. You had your normal blood test, you had your normal treadmill, you went to McDonald's, got an inflammatory fat meal, the internal milieu changes, that tightly held cap now will rupture. One reason is because the volume increases, and that's the second one. Those are shards of crystallized cholesterol. Those are the shards penetrating that fibrous cap. These are the shards penetrating the biomembrane, and then the resultant necropsy of the coronary artery where the patient died. Again, the lumen, the fibrous cap, the lipid core, the lumen ruptures, clot occurs. The progress, early cap, thick cap, rupture prone, ruptured cap. This happens every day. This is another test, LPPLA2. This little protein attaches to oxidized cholesterol, LDL preferentially. It comes through the intima. It is split off here, and some of it leaks back into the blood. So we can tell from this if we have adequate cap coverage and structure over those caps to hold it. This shows necrotic lipid core that is high in the LPPLA2. This shows another clot. This is the most important thing. If after 1 year of myocardial infarction, if I have a level here of 166, 98% chance you will not have an event in the next 4 years. Precision tool. We have a 5-pound fat model in our office. We would do a gullet measurement of the abdomen, and we would tell this man, you have 13 of these 5-pound fat models. If I sliced you in two, there would be nothing there but guts, organs, and fat. Now you have a new endocrine organ that's generating inflammatory products that destroys not only your vasculature, but the rest of your body. If you think of this smorgasbord as what you have already eaten circulating in your bloodstream. The eaters will be the cells, and what's left over will go to the liver, and what the liver and the cells can't handle has to be stored someplace. Stored in skeletal muscle, stored in cardiac muscle, stored in pancreatic beta cells, stored in liver. The fatty liver is now the most common cause for cirrhosis of the liver, and stored in the arterial tree. By doing a central ultrasound, like the CIMT that IMED is representing at this meeting, you can see this. See the bulge here? Like the fat man's belly? You see the regression here? You see the regression here. Now we have another precision tool that demonstrates to the patient anatomical evidence, not just a blood value, but anatomical evidence. And I use this primarily to get compliance from the patient, which is very hard to get. This just shows the same history of occlusion occurring and the mortality risk. And notice sudden death, even down here it's early atheroma. This is a measurement that's done. Cap, pool, blood flow. So you can measure the inside of the artery to get the diameter of the artery. You can measure the cap. It's called a carotid intimal medial thickness. That's covering the pool to get some idea how well your therapy is doing at a precision level. Carotid, bifurcation, plaquing with calcification. These are studies that demonstrated lowering of LDLs, 170 dropping down to 90, regression or slowing of the progression rate by LDL. This demonstrates diameter stenosis in the asteroid down to 60. This is 2 years ago, years after I just told you that our target was 60, 60, 60. But this is still slowing of progression and change in percent of the stenosis. Remember, the stenosis, when repaired by stents or bypass surgery, only gives you more activity, doesn't save your life. Stenosis decreased, changing. HDL, again, diameter decreasing as the HDL gets higher. Plaque, percent change in HDL. All of these studies demonstrate by changing your HDL, you can have regression, not just slowing of progression of vascular disease. This demonstrates Steve Nissen's studies with intravascular ultrasound. This is an invasive technique, but this study also shows that this plaquing was less. But it wasn't less enough to call it regression. It's slowing of progression. The reversal trial, or recent IVUS, this again demonstrates as we get the LDL down to 60, we can slow the progression. This is the report from IMD, gives the aging compared to a data bank. And when I can look at a patient and say, on your LPPLA score, 98% you will not have an event in the next 4 years. I can look at the Framingham and say 97% chance you won't have an event in the next 10 years. Then I can tell the patient, we have reversed your vascular age 5 years in the last 12 months. I have a patient that's willing to listen to me. This has to do with the efflux of HDL from the cholesterol plaquing to the liver. If this HDL is of the small variety, it has 1/3 the lifespan of the HDL of the large variety. It gets lost in the glomerulus of the kidney, and when it takes its load of cholesterol back to the liver, it's endocytosed or chopped up. But if the particle is large, it goes to this receptor site, unloads, goes back and gets some more. In addition to that, I now have 4 different mechanisms of reverse cholesterol transport instead of just one from the smaller particle. So is it making more sense now about the Barzillai gene for longevity? This is a black male measurement. This would be called the near wall because the probe is here, and the far wall. And this is the CIMT. This is the measurement tool placed on it. This is the measurement tool 15 months later. And this is thinner than it was. This is the same, showing the measurement here and later. Same. And this is the report. Notice the patient aged 1 year, his vascular aging receded 5 years. That should be exciting. We've known for a long time that you can partially reverse vascular aging, but what I'm showing you today is how rapidly you can do this if you have a precision tool to tell you that you've done it and add to the compliance of the patient. This is a woman, same type of measurement. Notice her age increased 1 year, her vascular age receded 4 years. So when I was in medical school, it was called hardening of the arteries. You tell somebody it's hardened, they think of table, nothing moves. What I hope to generate is the interest in this is not all hard. There's a liquid pool, there's a more solid pool, and then there's a calcified pool. Now this is very new information, and I don't know how long or how many years we can do this. This is just 1 year. This is a male. Notice what's possible. His age was 42. His vascular age is 22. So if we can engineer negligible vascular senescence by telling the genes which particles to make and which size to make them, can we take those other patients back to 20 years younger? And can we seal all of those caps to prove they cannot have an event in the next 4 years because the cap is so structurally sound it doesn't leak? And can we tell how many white cells are in the blood vessel walls to demonstrate they are unlikely to be enough there to take the cap off and cause the clot? And the answer to all of those is yes. This is one study that showed the enhanced trial that's been a lot of furor lately, but the study probably never should have been done. This was familial cholesterol hyperlipidemic patients, hypercholesterolemic patients, who were already on 80 milligrams of Crestor, and they gave them 10 milligrams of Zetia, and the news media says the Zetia doesn't work, the Vytorin doesn't work, why use it? You can't use a drug that slows progression to cause regression. And if you're measuring CIMT, this is what you get. You get no effect after you're on maximum dose of the statin. Next, 5,000 years later, the vascular engineer, the modern vascular engineer, prevents the disease reverses the disease, engineers negligible vascular senescence. So is it possible that we can engineer the vascular biology so that you cannot have a heart attack or stroke? If we can, that's $460 billion a year. If $460 billion a year, would that be enough to convince corporate medicine that we have something to offer? Now, this is one of the most important slides today. This is the normal progression of plaquing in the artery. If one gave that person Pravachol 40 milligrams, you would not see a difference in the progression. If one gave 80 milligrams of Lipitor, you would see decrease in progression. If one gave 40 milligrams of Crestor, you would see regression, but not significant enough to be called regression. Notice what targeted adequate precision therapy does. This. Normal, one drug, targeted adequate precision therapy, measured 2 to 9 years, erased out of that vascular plaquing in 12 to 15 months. Now we get to the Sweetie and I sailing away, and I want to thank every one of you for your kind attention.